And I'd like to present again our Renaissance surgeon who is not only a specialist in adult congenital and thoracic transplantation, but also one of his favorite things to do is operate on the aorta. Dr. MacGillivray.
I'd say coming from Boston to Houston to do aortic surgery is like bringing sand to the beach. A lot of aortic surgery done down here. Not only a lot of it done, but a lot of it done very, very well. So with that, aortic aneurysms, we know from natural history studies that they tend to grow at different rates. Certainly the ascending aorta grows at about a little more than 0.1 centimeter a year. Descending aorta and thoracoabdominal aorta grows a little bit faster than that. I mean, imaging has been an incredible change in the course of my medical career. Not only can you diagnose aneurysms, but you can really closely follow them serially to monitor their growth and help you plan electively when to intervene. There are some inflection points that generally speaking, the risk of rupture or dissection tends to go along with the size. It's unusual when you get below the size of 5 centimeters, but that risk goes up a little bit. And certainly once you get above 6 centimeters in the ascending, it goes up significantly. That being said, size is really a pretty gross tool to decide the risk of rupture or dissection. There's more work being done now on 4D imaging to help us understand when we should intervene in some patients. Patients, as you know, rupture at smaller sizes, and some patients can have pretty big aneurysms that didn't rupture, obviously, in the meantime. But generally speaking, the bigger the aneurysm gets, the more risk there is of trouble, of dissection, rupture, and death. So once you get above 6 centimeters, the yearly rate of rupture is about 16%. It's a little bit skewed because we obviously don't let people get bigger aneurysms. Our natural history studies are a little bit skewed. The guidelines would say that in the absence of a connective tissue disease, you should intervene when the aorta is 5.5 centimeters or greater, depending upon the connective tissue disease the patient has. And as we learn more and more, most of these patients that develop aneurysms probably do have some kind of unnamed connective tissue disease. But for those named diseases, certainly for Ehlers-Danlos or for Loeys-Dietz, we recommend replacing the ascending aorta at a smaller size than 5.5 centimeters. Aortic dissection, the most common catastrophe of the human aorta, has an incidence of about 3 per 100,000 per year. It's a life-threatening condition, and the mortality goes up with every hour. So survival of the patient is very dependent upon a prompt diagnosis and prompt therapy. It can be, even though these patients have classic signs often, they sometimes don't, and a delay in diagnosis is associated with an increase in mortality. There are several different classification systems. Here in Houston, we still use the DeBakey classification. Type 1, ascending aorta arch and descending aorta. Type 2, just the ascending aorta, not the descending aorta. Type 3, just the descending aorta. The Stanford classification is pretty simple. If it involves the ascending aorta, it's a type A. If it doesn't involve the ascending aorta, it's a type B. The breakdown is about 2/3 roughly of dissections are type A dissections, and a little more than 1/3 are type B dissections. The classic presentation is terrible, tearing, ripping, awful chest pain. You talk to the patients and you almost think they're histrionic, and you look at them, they look like they're generally in terrible pain. And it's different from ischemic heart pain. Patients talk about, oh, it's a pressure, it's a tightness. It's very different. But about 15% of patients don't have any pain, and they can present with a number of other different findings. CT or TEE are the two most common ways that these dissections are diagnosed. They have a very high sensitivity and specificity rate. The initial management, the ABCs, get invasive hemodynamic monitoring in them as soon as you can and start anti-impulse therapy. That's anti-impulse therapy, not antihypertensive therapy. The rookie move is to start them on vasodilators, nitrates, and that can increase the shear forces in their aorta and increase rather than decrease the risk of extension or rupture. So beta blockers, calcium channel blockers. You do want to be aware that in patients who have aortic regurgitation, and that's a significant number of patients with type A dissections, that giving beta blockade can slow the heart rate down and make that aortic regurgitation more significant. The treatment for acute type A dissections is surgery. It's surgery as soon as possible. As I used to tell my residents, you want to think of a type A dissection as holding a hand grenade in your hand with the pin pulled out. You don't have a lot of time. And a patient that can look very stable can become dead very quickly. Type B dissections are treated with some kind of intervention, at least for right now. Uncomplicated type B dissections, and we'll get into what that means a little bit, best medical management. This is from the IRAD database, looking at the mortality rate for type A dissections. It goes high very fast, very early. So again, the treatment for that is surgery. The goal of treatment, generally speaking, for acute type A dissections is to keep the patient from dying. It's not to resect the entire dissection. It's not to reestablish flow it's not to resect the entire dissection. Most of the problems that will cause death of the patient can be managed by replacing the ascending aorta. That includes the most commonplace patients will rupture, is in the ascending aorta, causing either exsanguination or tamponade. Aortic insufficiency is a very common cause of death in these patients, and that can be corrected by replacing the ascending aorta. And by reestablishing flow in the true lumen, you can treat a lot of the malperfusion syndromes. Even in patients that are promptly operated on, if you look at the IRAD database, still the operative mortality rate's about 20%. Part of that has to do with most dissections are taken care of at places that don't see a lot of them. If you look at results from busier centers, the rates are somewhere in the high single digits, but by the IRA database, it's about 20%. Approach to type A dissections through a sternotomy require cardiopulmonary bypass. The degree of hypothermia, we're moving away from profound hypothermia and even deep hypothermia to more moderate hypothermia. There's been some data to show that the outcomes may be a little bit better. Have gone from total circulatory arrest to some degree of cerebral perfusion, whether it be antegrade or retrograde cerebral perfusion. In doing that allows you to do an open distal anastomosis, which allows for a more precise and better anastomosis. Another thing that has been a trend is moving away from the femoral artery for the preferred site of cannulation to something more proximal, either the axillary or axillary subclavian artery or in the innominate artery. That allows you a peripheral site, but at the same time can give you access to antegrade cerebral perfusion if that's your preferred method. Retrograde cerebral perfusion, which was originally described for massive air embolism, has been used at some centers with very good success at increasing the amount of circulatory rest time for brain protection. That technically is your blood is flowing up through the superior vena cava into the brain. Antegrade cerebral perfusion. This originally described was to directly cannulate all three of the arch vessels and have blood flow grow antegrade up the arteries. Many of us, including me, generally we go and cannulate through a sidearm graft on the axillary artery. That gives you an uncluttered field, making either doing a extended hemiarch or a total arch replacement easier. What to do with the arch? As I said, I mean, there's a lot of people now reporting saying that you should do something to the arch at the time of the original dissection. And I think that depends on a lot of things. Certainly, I think you should have a stable patient that's hemodynamically stable and doesn't have some kind of malperfusion. An experienced team. If the arch has an aneurysm in it or a complex tear, that would be a good time to deal with that, because we know that those patients have an early incidence of degeneration, and certainly patients with connective tissue disease, whether it be Marfan's or Loeys-Dietz syndrome. Another marker for early aneurysmal degeneration of the arch is a large tear on the subclavian artery. So if you have the ability to replace the arch and stabilize that, that would also be an indication to do an arch replacement. And that can either be done with a conventional arch replacement or by doing a frozen elephant trunk. Frozen elephant trunk is deploying a stent graft through the opened aortic arch and under direct vision deploying that, and then either leaving, in this case, the arch, or most of us would replace the arch and sew it right to the TEVAR. As for proximally, depending upon, I mean, most of the time you can do a supracoronary tube graft. If there's disease of the aortic valve or a very complicated dissection in the aortic root, you can do a composite root replacement. More and more, certainly in younger patients, good success with valve-sparing root technique, preserving the patient's own aortic valve and reimplanting the coronaries. The mechanism of AI, even severe AI, there are several, and many of them can be stabilized with doing aortic surgery and leaving the native valve behind. Dilation of the sinotubular junction can cause incomplete coaptation of the cusps. The dissection can tear off a commissure that renders the valve incompetent, or you can even have prolapse of the septum across the aortic valve, causing aortic regurgitation. So at the time of surgery, inspect it, and even with severe aortic regurgitation, in the absence of native valve disease, you can usually spare the aortic valve. The root, even if the dissection extends into the root, oftentimes you don't need to replace that root. The group at Penn has shown, and many of us use, this neomedial technique by putting felt inside the dissected portion of the root, and the long-term outcomes of that for freedom of reoperation is actually quite good. Whether for aneurysmal disease or for dissection, valve-sparing aortic root replacement is a really elegant operation to take out aneurysms or dissections. This shows the mobilization of the aortic root, the aortic valve in the center. The coronaries have been mobilized off as buttons and get below the level of the aortic annulus into the left ventricular outflow tract. And then an appropriate sized graft can be telescoped over that to stabilize the ventricular aortic junction, and the aortic valve can be reimplanted into that graft, and the coronary artery is reimplanted. This is data from Emory in acute dissections, where they have a big experience with valve-sparing roots, have an excellent survival, and their freedom from aortic valve replacement is hard to beat. Over time, their reintervention rate is quite low. Type B dissections, I'd say our thinking on that has changed, at least my thinking on that has changed over the last 10 years. Unlike type A dissections, where surgery is the most important therapy, we learned early on that operating on type B dissections has a higher mortality than treating them medically. And so certainly open surgery or intervention is reserved for the complications of a type B dissection, and that best medical management continues to be the best treatment. What do I mean by complicated or uncomplicated? So about 3/4 of type B dissections are considered uncomplicated, meaning they have stable hemodynamics. They don't have any clinical malperfusion, and their pain can be well controlled with antihypertensive therapy. Complicated dissections, those are dissections that are leaking or about to rupture or have ruptured, have clinical malperfusion syndromes, or have rapid aneurysmal expansion. Refractory hypertension on 3, 4, or 5 drugs, or despite aggressive medical therapy, have persistent or uncontrolled pain. TEVAR has been a bit of a game changer in many ways, certainly for complicated dissection. The benefit is that it will close the entry tear and redirect flow through the true lumen, just like we do with an ascending dissection, and it can and does remodel the aorta, not only the ratio between the false and the true lumen, but actually the total size, and decrease the need for further interventions. The risk of a TEVAR, certainly early on in acute dissection, there is a risk of turning that type A dissection into a type B dissection into type A dissection. There is a risk of stroke and paralysis. And certainly patients that have dissections extending into their abdominal component, you can create new entry tears and accelerate the rate of aneurysmal degeneration in the abdomen. The INSTEAD trial was done and reported almost 10 years ago, where they compared TEVAR versus optimal medical therapy. And at 2 years, what they showed that there was really no significant difference between medical therapy and TEVAR, which kind of threw a wet blanket on the use of TEVAR, not only with aortic death, but overall death and progression of disease. They followed those patients out longer, the INSTEAD XL trial, and it's actually pretty interesting that after 2 years, again, with many things that we see in medicine, that the rate of death and aneurysmal degeneration did indeed accelerate, and those patients that had TEVAR placed did much better in the long term, at least, and they're still collecting that data. Very important to follow these patients with any kind of aortic pathology after they're repaired. Dissections are certainly the gift that keeps on giving, so you want to have a regular scheduled follow-up with imaging. So anyway, thanks for your attention. We've learned a lot and continue to do a lot in aortic disease. And it is as Dr. Scheinbein pointed out, it is a team sport, and you can take patients with terrible problems and get them better. Thanks very much.